I want to say thank you to the FMAC and Lisa for putting this on tonight. It's always fun to get to meet new faces and new students interested in family medicine, and always fun to get to talk about the cool work that we do. As Lisa mentioned, I'm core faculty at Lancaster General Hospital in Lancaster, Pennsylvania, and I'm an HIV specialist and I'm a family doctor. So I love to put the two of those things together and make HIV medicine one more way that we as family doctors provide comprehensive care for our patients. My work at LGH focuses mostly on outpatient care, but also at our inpatient hospital. Those are the two places where I spend most of my time. So what we're hoping to do tonight are a couple things. So we prepared about a 5-minute case, which will get you thinking a little bit about what HIV care can look like. And that may prompt some questions or some discussion. And I also want to spend a little bit of time talking about what HIV education looks like in family medicine in our particular context. And we can talk a little bit more about that outside, across the country a little bit as well, if you have questions like that. My goal is to be done with our talking in, about 15 minutes and leave the second half of our meeting just for questions and for open discussion. It looks like we're getting close to about 20 people. This will be a nice crowd for chatting, and I think opportunity to have questions. So Andy and I have both put our emails in the chat, and we will definitely be happy to hear from you afterward as well. So that's me. I'll let Andy introduce himself, and then he can launch right into our case.
Hey everybody, great to see so many faces and everybody who's joining virtually. I am a third-year resident. I am from Central Pennsylvania, and I did medical school in Boston area, and then was excited to come back here to LGH to do residency. I knew I wanted to be in a program that really did full spectrum family medicine, and then had opportunities to work with and treat patients who were living with HIV and folks who are dealing with substance use disorders. And I knew that this was a program where both of those things would be possible. During my first year of residency, I had the opportunity to work with Dr. Nisley and some of the other providers who are both family physicians and HIV specialists, and got to learn about sort of the unique additional training that we can get as residents here in the LGH program in order to get certified to be one of those HIV specialists afterward. And so I have been taking part in something called an area of concentration, which allows me to have some additional clinic time working with Dr. Nisley and his colleagues in a clinic that is primarily dedicated to treating and caring for patients living with HIV, but also those with substance use disorder, and now a growing LGBTQ community who is seeking care in that clinic as well. I also wanted to thank FMEC, because that was one way that I got an opportunity to learn a lot more about family medicine and get exposure to some awesome family medicine mentors. So I hope you all stay connected to that organization and use us and them to continue to pursue your interests and find people who inspire you. So with that, I think we can dive into our brief case presentation here. Like Dr. Nisley said, this was just a chance to sort of get your mind thinking about the possibilities of what HIV care could look like in a future practice for you in family medicine. And then we can talk more about what that looks like in our practice here in Lancaster. So this was a case that Dr. Nisley and I pulled from our experience. This was somebody that I actually saw in our rural clinic, which is about 20 miles south of Lancaster City. And a patient who had come and was actually establishing care with our practice. So had sort of been bouncing around and not had a real primary care physician or family doctor for many years, and was looking to reestablish care after finally getting insurance after a couple of years. So this was a 25-year-old male who had a past medical history of anxiety and depression, who came to our clinic for establishing care. He told me that he had dealt with depression and anxiety for as long as he could remember, at least back into his middle school years, and had worked with a guidance counselor there. And then when he was older, he did have a pediatrician who had started him on some medications for anxiety and depression. Eventually, he was referred to a psychiatrist for that, but wasn't able to follow through, didn't have a good relationship with the psychiatrist, and then also found it very inconvenient because he lived in a rural area and had to travel quite a distance to get to see that psychiatrist. So most of the first part of our visit was us exploring his anxiety and depression, and that which was really the main thing on his mind at the time. In our first visit, he really didn't have other specific concerns that he wanted to talk about. But I think as all of you who are going through medical school and having to go through the full HPI, getting that social history, that family history, talking about sexual health and sexual history, knowing how important that is, that was something that I tried to do with this patient's initial visit. And so we talked a little bit about his social history and where he was working, things like that. And then I asked him for permission to ask him about his sexual health, which he was open to. And he disclosed to me that he identified as a gay man, that he had exclusively male sexual partners, and that in the past year, he'd actually had five sexual partners and 5 different partners, a few of whom he'd had relationships with, but several of whom he did not know well. As part of that, I wanted to ask him if he had ever been tested for HIV or other STDs, and he thought that he'd been tested for HIV once and was negative, but he had never been tested for any other STDs. So based on that, one thing that sort of popped into my mind as somebody learning about HIV in primary care was, based on this person's sexual history, is this person at higher risk for acquiring HIV, and is there something that I could do about it? And is our patient interested in doing something about it? So I discussed with him that having multiple partners, including partners that he had not really known too much about, or their sexual history, or who else they were interacting with, but put him at higher risk for HIV, as well as being in a community that identified as men having sex with men, or the MSM community. And he was concerned about STDs and was also knowledgeable and concerned about getting HIV. But he did not know that there was a medicine he could be taking to prevent HIV. And that medication broadly is a class called PrEP, or pre-exposure prophylaxis. So we talked about that for sort of the second half of our visit. And we talked about what that would entail and why it would be a helpful medicine for him. And actually, after that visit, I followed up with him by phone just a few days later, and he had decided that he wanted to start that. So we started that medication for him. And I have seen him probably 4 or 5 times now in the last 6 months for various things, but we've touched base each time about his sexual health and taking his PrEP medication. And that has been going really well for him. I think one thing I just wanted to point out for the reason to share this case is, I think one of the things that inspires so many of us in family medicine is getting on the preventive side of things, and not just seeing illness once it's sort of far progressed, but stopping it even before it starts, and helping somebody feel both empowered and in control of their health, and having a good understanding of what their options are for their healthcare. And I thought this was a good case that demonstrated some of those principles, both prevention and trying to help prevent HIV even before someone acquires it, and then helping them understand their options for prevention, and then treatment if they were to acquire HIV. And then lastly, having an open space that someone can really feel like they can talk about their sexuality, they can talk about their concerns about STDs or HIV or other conditions that have been wrought with stigma for many years in the primary care space, where we're also talking about the other medical issues that are going on.
Awesome, Andy. Thank you very much. Um, I imagine that stirred some questions or some reflections from each of you, or maybe some thoughts of like, hey, this is what I would do next. Um, and definitely Andy gave us some things that he did in an exemplary fashion too. So I'm gonna keep talking for a few minutes, but if that jogs something in your mind you want to come back to or jogged a question, go ahead and put it in the chat and we'll get to it in just a little bit. Let's kind of shift gears a little bit and talk about kind of HIV care in family medicine in general. So we here, I think across the specialty, but here at LGH, we believe that HIV education is a core and necessary part of every family medicine resident's education. Pre-exposure prophylaxis and PrEP, for example, prevention and testing for HIV are all things that we think every family medicine resident should leave residency feeling familiar with and having a good sense of what's going on. And even the basics of treatments and management is something that everyone should have a working knowledge of, basic testing and things like that. So definitely something that you should be coming up against no matter where you do your training. And when you think about, HIV treatment and the history, this is definitely something that for many years has often been in the grounds or in the domain of infectious disease. And that's certainly where a lot of the initial work for the disease was done. But that is certainly something that is changing as our population grows, as we have more and more patients who are positive. And as the treatment changes, including the introduction of PrEP, for example, we believe that it's moving increasingly into the domain of to primary care. And while where all residents should have at least some working knowledge of HIV care, there are definitely at least many family doctors out there that are comprehensive HIV providers, and we think that's definitely an excellent skill that you can attain as a family doctor. I think maybe if I talk a little bit about like the context at Lancaster, that might give you more of a sense of what things happen. So here at Lancaster is a little bit atypical. So our clinic, comprehensive care, was actually founded by a couple of family doctors, people who are faculty of our residency. And so as a result, more than 90% of people who are HIV positive in Lancaster County are cared for by family doctors as opposed to infectious disease doctors. As Andy mentioned, we have a training pipeline here for third-year residents who get to spend some of their continuity clinic each week at comprehensive care and do some concentrated elective time there as well. And so the residents that get to do that AOC, that can choose to do that AOC typically actually sit for the HIV specialist exam through the American Academy of HIV Medicine at the end of residency. But all of our residents have the opportunity to do some rotations and some time at comprehensive care as well. I think that's done differently in different residencies. There are other residencies across the country that also have a track or an area of concentration as we do. There are other places that have rotations or electives, and there are some places that choose to offer fellowships. And we've actually had one of our own graduates recently do an HIV and LGBTQ health focused fellowship. So there's a variety of different ways that you can pursue that. And that's done a little bit differently across the country. I think it's worth noting that the AAHIVM, the American Academy of HIV Medicine, is very supportive and kind of provides a variety of mentorship and educational and CME opportunities that really make it really feasible to do HIV primary care kind of wherever you're at in the country or in practice setting, and even have some mentorship opportunities for patients, for doctors that might have a low volume practice that needs some support if a tricky question comes up, for example. Kind of as Andy alluded to, comprehensive care is a place where we merge a variety of sort of overlapping risks and overlapping experiences, things like substance abuse, sexual minority groups or LGBTQ care, gender affirming care, hormonal therapy particularly is managed by a couple of my partners there. Hepatitis is something that we are very familiar with managing as well. And these things often are things that we are seeing in the same vulnerable population groups. So I find this to be a super fulfilling part of my job, an exciting part of my job. It's also something that we get to see on the inpatient service from time to time, sometimes truly because of HIV and its complications, but also other times just because our patients are aging and getting other medical conditions that go along with getting older. So I think that's maybe enough of a basic introduction to what's going on. We are about halfway through our presentation. So I think at this point, let's open it up for some discussion and some questions. I see at least one of those in the chat, and so I can get to that one. So what kind of community resources exist in your community to support patients who are positive or more hesitant about screening and PrEP? And are there resources to help educate patients who may be less knowledgeable? Yeah, there are. So we have a couple of agencies locally who do, for our HIV positive patients, who do community-based case management. So a group called Alder Health and a group called SACA, which is the Spanish Hispanic Center in our county. Both of those places do case management that is funded through the federal Ryan White grant. So that can be a really great opportunity. Alder Health, which is an LGBTQ focused group, does a lot of support groups and that sort of thing. And through our Ryan White funding at Comprehensive Care, we have a lot of opportunity to devote resources to help our patients. So for example, we've used funding to help patients with housing. We've used that funding to help with helping with dietary needs, providing healthy meals, for example. We actually recently had some funding to purchase a mobile van, and the hope is to expand into doing some more HIV testing events, maybe even PrEP events, other things around the county too. So that's a little bit of the beginning of what we're doing. It's actually kind of interesting. For our patients who are positive, in many ways, we have more resources than for our patients who are not positive. Pennsylvania is a Medicaid expansion state, which really helps a lot. But even for we still tend to have patients who are uninsured. And for my HIV positive patients, I can tell them, don't let costs be a reason not to come to us or not to get your medicine, because we have ways to find funding through Ryan White grants, which was a federally funded program, and other ways to make sure patients can get their medicine, when I can't say that for patients who aren't always HIV positive or who aren't HIV positive, for example.
One thing that the clinic has done in the last year to try to expand the access for testing and the discussion of PrEP is to create a free STD clinic using additional funds, so that people can come and get tested on Monday evenings for any STDs, but including HIV, of course. And that is often a place where people also come to discuss PrEP, and that word has sort of gotten out through the community, I think through a number of venues, but a lot of sort of word of mouth from person to person. And our county is big, but it's not that big. So word gets out pretty quickly. And many of those folks have come and gotten started on PrEP actually just from coming to that clinic, and then reconnect with either their primary care physician, or they just continue to return to that clinic every few months in order to get their repeat testing. And I think expanding that is something that it will definitely be in the future of Lancaster.
So our next question is, how is the exposure to research during family medicine training, and particularly in terms of HIV care? Andy, you want to take a first stab at that one?
Yeah, I think, as Jared said, I think depending on the residency program that you're at, that will be a specific question to definitely ask, and ask for examples of how students have gotten involved in that research, or sorry, residents have gotten involved in that research specifically. For Lancaster, I would say during our intern year, there is not a ton of space in order to do research projects where you maybe would be pairing with a faculty member and doing a primary investigative work like within the HIV clinic, but that's an opportunity that in your second and third year, as you have more elective time, you could pursue. I think many people in, or some more recent examples of how people have tried to incorporate an academic lens or an academic focus in their HIV training is to to help write articles that allow you to discuss up-to-date guidelines or more recent guidelines, and then also review topics that are related to HIV and primary care. And that's an opportunity both to really get up to speed on an important topic within HIV care and have a chance to still be sort of very close to research itself. I think the challenge that we have is the 3 years are short, and the actual time that you would have to really invest in a long-term research study is hard to come by. The one positive that we have at LGH is we are, I think, the only community hospital in the country that has its own research institute. And so if that's something that you're interested in, there are folks at the Research Institute who can pair with you to actually provide some of your biostatistics or statistics analysis, as well as helping you work through, we use the EMR Epic here to actually do the type of chart reviews and data mining that you might use to do a research project. So is it common that people do it? No, I think it's less common, but is it possible? Absolutely. You would just sort of start early and identify your mentor, which we have many within our program to sort of get that done.
As Andy kind of alluded to, we have an expectation that all residents are going to do some sort of academic project and research project during their residency. And the American Board of Family Physicians also is requiring all residents to do a quality improvement project of some sort during their residency. So the practice manager of comprehensive care, for example, is Dr. Lake, and Dr. Carries is his partner. Those two are recent graduates of the program. They're very familiar with the program and love to work with residents. So they're super open to ideas and trying things out. And they have a lot of ideas themselves. So they're, I think, happy to put residents to use to achieve some of those quality improvement projects. All right, so any tips on engaging teenagers, young adults with HIV who are sometimes understandably tired of having a chronic condition? Yeah, this is a really tricky one. So fortunately, we do not have a lot of children that are HIV positive in our community. I know of a few, but most of our patients at comprehensive care have acquired HIV in adolescence or early adulthood. And so I can't say that I have a lot of experience specifically with HIV in teenagers, but I do have a lot of experience caring for teenagers and young people. And I think that in and of itself is a strength for family medicine doing, HIV care as opposed to infectious disease or specialty driven infectious disease, HIV care. And I think it's really all about building rapport with the patient and helping them know that you are their ally, you are in their court, you want to help them, not punish them. I think Andy's case is maybe illustrative in this case, and that this is really the group of folks that don't perceive their risk, don't realize that there are things that they can do. And so asking about sexual history, sexual practices is really critically important, because you may be the person that identifies someone's risk and prevents them from acquiring HIV to begin with. For our patients who have been dealing with HIV for a long time and are tired of it and don't want to deal with it any longer, this gets really tricky. And I think there are some exciting new things that are happening. I think perhaps you guys have heard about Cabenuva, which is now injectable ART, which is on the market. And we're starting to offer that to a lot of our patients. And patients are really excited about it. It's really, there's a subset of patients that are really tired of taking a pill every day. And so the option of getting an injection once a month or once every 2 months is really exciting and liberating for them. So I think that for some of those patients, that may be an interesting solution there. In many areas of healthcare, we've seen the pandemic has furthered existing disparities. PrEP requires regular testing. I'm curious if you've noticed any impact in your HIV and PrEP clinics. I wish I could say that we had data about this. We don't have data about this. I agree that it's likely the case. We have not seen a major change in our adherence to medication, adherence to office visits, and HIV control among our patients who are positive already. But in terms of rolling out PrEP, I think that certainly the pandemic had a big effect there. In terms of the disparities, I mean, yes, the Lancaster County certainly reflects the national statistics, where if you are, for example, a man who has sex with men, you are much more likely to acquire HIV if you are Black or Latinx or non-white. And so that reality is true across the country, and it's also true here. And so I think that the onus is on us to be targeting our PrEP and outreach to those communities as well. And I think we're doing that. And I don't have specific data to say that that's the case, though.
The one thing I was going to add, Jared's point of Lancaster being sort of a microcosm or a reflection of national trends, definitely true for the groups that he mentioned, as well as the disparity between rural and urban care. And that's reflected in the data that came out with the 2021 guidelines about PrEP, showing that likely due to greater stigma in rural areas, providers are not asking patients about PrEP and not offering PrEP at the same rates as urban providers and urban-based providers. And so that's another thing that I think we can work on and have access and the resources to make that happen through the residency, given that we both work in the urban environment and our rural clinic. In this case that I offered today was from the rural clinic, actually. That also sounds like a great research project if somebody wants to come to that.
The next question is, does insurance generally cover PrEP? Yes, PrEP is very well covered for insured patients. And in fact, there is now funding nationally for uninsured patients to also get PrEP. You can get free PrEP through a number of national pharmacy chains, I believe CVS and Walgreens. So PrEP access is dramatically improving in terms of coverage. There are some recommended lab tests, particularly HIV testing every 3 months ideally, and hepatitis B testing and some other basic tests which are helpful. So those may be a little bit trickier to get covered, but those tests don't tend to be quite as expensive as the medication itself.
Hi. Oh, sorry.
Hey, go ahead.
Okay. Hi, I'm Laura. I'm from Rutgers NJMS. So usually where I am, HIV is under all of the infectious disease docs. But I think it's really wonderful that HIV care can be done out of family medicine, because there are so many incredible opportunities for preventative care for people living with HIV. So could you speak a little bit to like the scope of practice with patients that live with HIV? You're also taking care of like their pap smears, anal paps, and like all of the preventative stuff that like patients with HIV are at risk for, and how often are you doing that? Also, like addiction medicine like plays a huge role in HIV care too. So how often are you doing that?
Go ahead, Andy, or I see Marco's here too. Maybe Marco can jump into if he wants to.
I was going to say that's our bread and butter, Laura. That's what we do all the time. I think it's been kind of a interesting thing that since doing the area of concentration, I have many visits at the comprehensive care clinic where HIV is actually the last thing that we end up talking about during the visit, because we're hitting on all of those other chronic disease and preventive issues that are going on in someone's life. And for many patients now, taking one pill once a day and having routine labs every couple of months to ensure that their viral load is undetectable is the extent of most of their HIV care. And I think it is really wonderful and peace of mind and convenient when someone can come to that visit where they would have to go anyway to get their labs done or to have their HIV checkup, but also get their pap smear done, have a lesion looked at that they were concerned about, and maybe have that taken off or sent for biopsy, get their hypertension treated, perhaps talk about their pre-contraception or their contraceptive care, or they're thinking about having a baby. All of those things are things that I would say just in the last 2 weeks are examples of things that we talked about in clinic with patients who were there for their HIV care, but really there for their whole health to be thought about. And I think that's the best part of what we get to do in our training.
Yeah, 100% yes. I think that right there is the sales pitch for why HIV care belongs in family medicine. Andy didn't mention addiction care specifically, but all of us are prescribing buprenorphine, for example, for our patients that need it, and dealing with other substance abuse issues that come up all the time: alcohol, nicotine, tobacco, increasingly methamphetamines are issues that we're also seeing. And I think the other piece of that, which Andy sort of alluded to, is pregnancy care is something that we are very familiar with and very comfortable with, and that's not the case for, I think, the infectious disease world. And I think that's really an advantage that we have as well. Not to mention that we know how to assess our community's needs, go out in the community and find out what the resources are and take our care to our community as opposed to waiting for them to come to us.
Yeah, it's great that it could just be a one-stop shop like that. I did an elective at like an infectious disease clinic where like most of their patients were patients living with HIV. And that was my one gripe with it. I loved all of the patients and interacting with them, but the fact that they had to like go to gynecology for the pap smear, and it just seemed like a lot of back and forth. So it was so awesome that they could just get their care in one place.
So looks like we got time for one or two more questions. I see one here from Javon, who talks about the ruling yesterday by the Texas judge who said that individual companies may be able to exempt themselves from coverage from PrEP because of a violation of religious freedoms. And that was concerning to see that yesterday, similarly to how contraception was ruled on in courts a few years ago. I'm hopeful that that won't have a broad application, or there won't be lots of places that are applying that, or lots of companies or corporations that are not covering PrEP. Certainly, we're seeing our Medicare, Medicaid is covering it, and hopefully we will continue to see a strong push from the federal government to fund it, even if private insurers aren't covering it. So I really hope that PrEP continues to be accessible, and that's certainly been the trend. This court ruling notwithstanding.
If it's okay, I ask a question.
Yes, please go ahead.
So hi, I'm Molly. I'm from Central Michigan University. So we kind of have a weird curriculum, or a unique curriculum, where we do 6 months of family medicine in our third year. And we go out into really rural places. So I was in a town of about 500 people in Michigan's Upper Peninsula. But we found a lot of times that our patients who are living with HIV were really hesitant to disclose that to us as providers. And because of that, we really struggled in treating them. So I guess, what kind of advice do you have in, kind of creating a culture within your clinic where patients feel that they can disclose that? Because I think that's part of the issues that we ran into, is people just didn't necessarily always feel comfortable disclosing that in the clinic in such a small community.
Yeah, that's really tricky, especially if patients are worried that disclosing is going to out themselves to their family, to their friends. If maybe there are people that they know are working in the clinic, for example, that's really tough. I do still think asking and making a good sexual history a regular part of your visit is really helpful. I think that's going to help. And also asking about substance abuse. I think those two things are really going to help. I think they're really going to help open up your eyes about who might be at risk for HIV, and then implementing universal screening. I think that's another, and making us feel about I recommend all adults are screened for HIV. I think those sorts of things, if that's matter of fact as part of practice, I think that really helps. I think in a place like that, you have to be super vigilant about confidentiality And maybe you have to find another doctor in a different town for that person. And that may be a barrier, that may be transportation, but maybe telemedicine is what that person needs so that they can get care at home. But that is really tough. I think that visible and demonstrable allyship for the LGBTQ community in a clinic like that is really helpful, showing that we care about people who are gender or sexual orientation minority patients is really helpful. If if you are advertising that we are here for you, I think that patients really appreciate that, and it makes it much more likely for patients to bring up those sorts of things in the exam room. Yeah, but that's a tricky situation, and it's got real life implications for patients. And I think that maybe is a part of what's happening in like the rural South, for example, where we see a real explosion of HIV.
Yeah, I know the other part of it too is that we were a tribal health clinic, so we had the added barriers of it was a Native community, and there were other implications for passing on HIV and for being part of the LGBT community. So there were quite a few barriers, but that makes a lot of sense if you just kind of like normalize it and say it to everyone every visit. Maybe eventually they'll kind of just feel like it's a normal part. That makes a lot of sense.
Yeah, one thing to add, I asked a patient who has had HIV since birth about this, as he was someone who had been through many different clinics, including with infectious disease and family medicine, and had been through several different hospital systems within our area. And he mentioned two of the things Dr. Nisley said, sort of that signposting, that clinicians had something on their badge that showed they were an ally. They were wearing something that you could know this would be okay to talk to you about in terms of even something like sexual health but especially their HIV. And then the other thing that he mentioned was that he liked our clinic because he felt like it wasn't just the providers, but it was like that first person who was there when they walked through the door that was really welcoming and affirming to them. And that included like phone calls as well. And so maybe they weren't necessarily discussing, of course, like their HIV status, but that was the sense that he got, that this was the place for him. Yeah, so that was something else just wanted to add.
Thanks everybody for coming out tonight. Really glad to see all your faces. I will be at FMEC in a couple of weeks, and Pam Vanenchek, our program director, is also on this call, and she'll be there too. So we'll be happy to meet any of you. Andy and I put our emails in the chat, so happy to hear from you if you have questions or would like to talk more. Have an exciting year, and if you're fourth year, good luck on the interview trail. Perhaps we'll see you.